Hi, everybody, and welcome again to our conversation on COVID-19. Our guest today is from the University of Nebraska Medical Center, Dr. Ali Khan. He is an epidemiologist, got a lot of titles, right? Director, dean, public health, all sorts of things, right? You study this kind of stuff for a living.
I study this kind of stuff for a living, and my passion is making Nebraska the healthiest state in the union.
I mean, after all, you wrote a book about a pandemic.
I wrote a book about it, the next pandemic, exactly.
So for the next 45 minutes, we will be taking your questions for Dr. Khan. Let us know what is on your mind. Maybe some of the news of the day has shifted a bit. I thought I would begin with, you've been doing this like since mid-March, at least intense. I know you've been studying it for some time. Is there something that keeps being said over and over again that for some reason doesn't stick well with the public?
Okay,
like they just don't understand. Is there something that rises to the top?
Yeah, so let's talk about a couple of things. That's a great way to start. Actually, when you said you've been doing this for a while, I thought you were going to say 1991 when I started out as a disease detective at CDC, and I'm like, yeah, I have been doing this for a while.
That's a good title, though, disease detective.
Yeah,
that gives you some credence.
That does give you some street cred. So a theme that has been sticking with me for a while now is I think there's this false dichotomy between stay at home and open up, right?
Like either or.
Either or, right? And that it's going to be, so I think people need to recognize that it's never going to go back to the way it's been in the past, at least not without a vaccine or drugs available to us. But we can reopen safely, right? And I think people are missing the safe part. Right? So everybody comes to me. I do consulting gigs, people, the college consults. I chat with numerous mayors, governors, etc. You know, we want to reopen schools. I want to reopen schools. I want my College of Public Health. I miss my students. I'll be very honest with you, right? But the best way to keep them safe, besides all the things we need to do in the school, is how do we drop community transmission, right? The students, the faculty staff will be safer if there's fewer people sick within the community. And that's the conversation I don't think we're having enough of, which is what are we doing to make sure we have fewer sick people in the community? And that's what we need to be focusing on. So it's not just we need to reopen America, it's we need to reopen America safely. And that is about public health. Right? That's the core thing. That's when you hear about testing. So it's testing for a purpose, right? It's about finding your cases, isolating them, finding their contacts, tracing them, putting them in quarantine. And what that does is it gets rid of the cases in the community, and then as you go out about your business, you can feel so much safer about sending your kids to school, going to work, going to restaurants, you know, all that business becomes so much easier if you have fewer people sick in the community. And so I think that's what I've been thinking about since March. You know, like I think I probably have as much quarantine fatigue as anybody else in America, right?
And you're talking about it all the time,
and I'm talking about it all the time. So absolutely, I understand the desire to get out and about again, but let's get out and about again in a way where we are doing it safely and continuing to drop cases in our community every day.
So let's dive a little deeper into that. So we need just to ramp up testing. I mean, because I think it's still to the point where everyone's still really protective of their supply. And if you're asymptomatic, many of those folks aren't being tested, right?
So correct.
And most people are getting sick and spreading it without knowing they're sick. That's the danger there.
So there's absolutely, so you spot on. So this virus has been so bedeviling because unlike many others, you are infectious probably 2 to 3 days before you're sick. So even if you're the most wonderful human being in the whole world, and the moment you get sick, you go, okay, I'm staying home, or I'm going to go see a doctor, right?
Like we would under normal circumstances.
Like you would under normal circumstances. Well, unfortunately, for the last 2.5 days, you've been out and about doing your business because you felt fine. But during those last 2.5 days, you've been infecting people. Right? And so it has made it very difficult to control this virus. So what we need to do is really get out there, find people who are sick, and then if you find their contacts and put them in quarantine, they can't infect anybody. right? So if their contacts are all in quarantine, they're not infecting anybody because they're sitting in quarantine. So if they get, if they get sick, they were sitting in quarantine when they got sick, so they weren't out and about. And so that's what contact tracing does. It makes sure anybody who gets sick, they're sitting in quarantine. Hello. Not infecting anybody, and then you just cut that chain of transmission. So contact tracing for me is all about cutting chains of transmission. That's how I see contact tracing. Keep cutting those chains of transmission until you get very little transmission within your community.
So if back in March, back in February, testing really was in the tens of millions, many states probably wouldn't have had to have any real stay at home, right? Because wouldn't you have been just testing all kinds of folks and knowing who to isolate rather than the whole town?
Absolutely. So this is the approach that South Korea took. So South Korea decided to take their first case, I think, was on the same day or the day before ours. And so basically what they did is they went to their 3 or 4 big testing manufacturers and said, we need to do a lot of testing. And they tested pretty much everybody they could, and they followed their outbreak, and they had very little shutdowns except for targeted shutdowns where they had cases. And now South Korea has, I looked yesterday, 4 or 5 cases a day for the last couple of weeks, right?
Yeah.
So they had a very different approach. We could have done the same thing. We could have gone to Abbott, Becton Dickinson, Cepheid, Roche back in January and said, a couple of 100 million tests, ramp them up. Here's a couple of $1 billion. You want $1 trillion? Here's a couple of $1 trillion. Ramp up testing and do it. And we'd have lots of testing and that would have allowed us to see where disease was coming from. And we would have made, the president made a great decision in closing borders, shutting down traffic to China, even when that wasn't popular, right? But we would have done it sooner, and then we'd have known around Europe. We would have done Europe sooner because we would have said, hey, with all that testing, we would have said, oops, all these people coming in from Europe who are positive, not a good deal, let's do that sooner. But we just never had a good handle on what disease was going on in the U.S. So,
and then once it got here,
it was here.
We didn't have the testing
to know what was going on. So we never had good data to drive decision making, and the testing is the good data to drive your decision making.
All right, we got some questions here that we'll get to. Carmen writes on our Facebook page, what do you see as the best treatment forward at this time? Antibody testing, constant testing, vaccine. I know you said a vaccine is well over a year away, probably.
Potentially. Okay, so Carmen, great question. So let's talk about the near future. Okay, so the near future for us is ramping up the existing testing, which is PCR testing, find cases in our community, pull them out of the community with isolation, find their contacts, and cut chains of transmission to decrease the people who are sick in the community. And lots of countries have done that very successfully, like Taiwan, cases in the ones and twosies, South Korea, New Zealand. They've all done this strategy, and China have gotten their cases down in the onesies and twosies, right? So we can do that right now. This is a near future for us. So then couple that with antibody testing, which will allow us to understand where disease has been in Nebraska and where it's going across the state. So University of Nebraska Medical Center is now doing some of that antibody testing. So that'll let us understand across all of Nebraska
just
how
like
many
where
people,
it's been, right?
Where it's been, exactly. Because right now the testing has really been focused on people who have symptoms, but that doesn't give you a full sense across the whole state.
Both of us could have had it and we didn't know.
We didn't know it, right? Exactly.
Yeah.
So the antibody testing will give us a much better sense of who's been infected, and if you repeat that every couple of 2-3 weeks, every month or 2-3 months, you get a better sense of how the disease is progressing. And then finally, the long-term option would be, yes, vaccines. There's hundreds of vaccines candidates. There's apparently 8 vaccines that are going through fast-track efforts, and some people, Dr. Fauci of NIH is optimistic that, January, February, we may well have a vaccine. So maybe, we'll see where that leads us. But yes, I'm always optimistic about what the future is, but the future never holds me up from what I can do today, which is let's find the cases in our community today and drop transmission in our community today.
And then worry about tomorrow.
Then worry about tomorrow.
Kathleen writes, do you have any specific recommendations for people over 70 as restrictions are lifted?
So, Kathleen, I'm going to have to be honest with you. people over 70 are the most susceptible to disease with getting severe disease within our community. So even if you look here in Nebraska, I believe 60 to 80% of our deaths, unfortunately, have been in people who are over 65 to 70 years of age. And that's been true as we look at data across the U.S. and worldwide. That is our high-risk group, males, elderly age, and then people who have high-risk conditions. So if you are elderly, you will probably be the last people who public health individuals would advise to go back out into their communities. So I would wait until there is the least amount of transmission within the community before you go back out into the community. And even then, please remember the face masks, the wash the hands, and the social distancing.
Because even recently, I think Douglas County was seeing its biggest infectious rate that it had seen. You know, like a week ago, it was like in the 20s, when for a while it was only in the 13. And I'm no math expert, but essentially it doesn't mean that you're doing more testing per se, because you'll have more cases, just showing how many, the percentage of people that are sick from those that are tested. So it's not like we're out of the woods.
We're not right. We're not out of the woods yet. So I would still be cautious. And for now, until we really have low rates across our communities, still please stay home. That's a recommendation. Have people deliver groceries to you, and just wait it out a little bit longer, please.
Jennifer writes, do you think there will be a second wave?
So, you know, I have to tell you, Jennifer, the older I get, the less certain I get and the less smart I get. So I don't think
that's for all of us, I think, Doctor.
I don't think a second wave has to be certain, right? It's possible, but if we can truly get on top of the cases within our community and drive down community transmission aggressively, and that means all-out commitment to public health at the national, state, and local level, I think we can prevent disease from resurging. But if we don't, then I agree with you. If we don't have that all-out commitment to keep cases low, then yes, cases will slowly start increasing within our communities. And I will give you lots of examples of that. So we know, for example, that in New York City, there were cases 3 to 4 weeks earlier than the large peak we saw in New York City. You can trace that back. And as people have started to look at cases in California, Ohio, and other places, they can find cases back in January before they started to see the rise within their countries. So we already know that you can have cases going on for maybe at least 2 to 6 weeks at low levels before they start going up. So if we don't invest in public health to keep cases down, a second wave is very possible.
And then it's hard to stop that.
And then it's hard to stop, as we saw in New York City.
Susan writes, is this just a form of the flu?
Susan, I have to be very, very honest with you. In some ways, I wish it was the form of the flu, because it wouldn't be so deadly. So no, it's not a form of the flu, Susan, for a number of different reasons. Flu is a human disease exclusively, and as we've seen from our Chinese colleagues and others who have been able to get this down into the low to zeros, you can't do that with influenza. Influenza is a year-round human disease, and we're not sure if that's 100% true for this. The other thing is, we now know with this disease that it's probably 10 to 20 times more deadly than flu, at least. So, for example, you see we have at least 80,000 deaths so far in 3 months of this outbreak in the United States, which would be a very bad flu year over the whole year. So no, this is much, much worse than the flu.
Linda writes, what recommendations for older than 60 to see their grandchildren?
Linda, goes back to my earlier conversation that individuals over than 60 are at the highest risk for having severe disease. And so my recommendations would be, until there really is a low risk of disease in your community, that you be very cautious of contact with anybody who may potentially be infected.
Because it's not so much grandma infecting the grandkids, it's probably more
The
likely the
grandkids,
grandkids.
right? It's more likely somebody else infecting grandma, because we know the children, even though they can get severe disease, they're less likely to get severe disease and more likely to have mild disease. So I'm not as much concerned about the kids as I am concerned about grandma getting infected.
We are here on Facebook Live on the WWT6 News page with Dr. Ali Khan. He is an epidemiologist at UNMC. A lot of history, studying pandemics, wrote a book after all. He was a disease detective for the CDC, along with like a whole list of different things. Surgeon General, I mean, you've got a pretty good little byline there in your resume, don't you? Hey, I wanted to ask this one. This is kind of maybe a little off topic as more people are firing away at some questions, and we'll get to.
No worries.
So I saw a Zoom that you did. I forget on which one, but you had some comic books in the background. Doctor Strange. Now you knew they were there, and you were like, "That's cool. I like that." So I loved that idea. That was pretty cool.
I did something at 10 o'clock at night or 11 o'clock at night, and so I did it from home as opposed to shooting in my office, and so that just happens to be my home office. So somebody
I thought that was neat, though.
on the back of my home office.
Did you get ribbing from your colleagues
Yes,
for
I
that?
got ribbing from my colleagues.
Have you changed what you have, or now next time you're not going to do it from your office?
It just happens to be my home office.
Are they calling you Dr. Strange now when they see you, your colleagues?
There you go.
Chris wants to know, when will visitors be allowed in hospitals?
So that's going to be, again, I think that's going to reflect what's community policy looks like. So I know we're resuming elective procedures, and God, I hate the term elective procedures because it makes it sound like they're like voluntary.
Right, 'cause a lot of
they're
times
not voluntary. It just means they're not an emergency procedure, right? And so there's some critical work that we've not been able to do because they're not emergency. But the point is, there's a couple of things. One is you want to make sure that anybody in the hospital is protected. We're testing people who are going into hospitals, and we don't want individuals to get infected. So the hope is that as we have more testing capability available, and as disease transmission goes down in communities, that we will allow visitors back into hospitals. But that's again in this staged process as community transmission goes down.
And that's probably way down the list.
That's down the list. And it's the same thing true, for example, no visitors in long-term care facilities.
Yeah, because I mean, those have been hurt. Those have been crushed.
Correct.
Okay, so we have one from Jay, who, a few different questions, but see if I can boil it down. Wondering if there's a scientific reason that state health not publicly disclosing new cases at meat processing facilities, and are there possible consequences of underreporting new cases? Is there a scientific backing to that?
Yeah, I don't think I can comment on that or know enough about why we're not reporting or potentially not reporting certain types of cases or where they're occurring. I don't believe that we're underreporting cases. As far as I know, the local and state health department are reporting all cases.
It's just not site-specific, I think.
It may not be site-specific.
I know the governor has not named specific places, and that must be what...
That must be what the question is.
Jimmy writes, Jimmer writes, why aren't they subtracting numbers? Is when people get well, all I see are the adding cases.
Why are they not subtracting numbers? Oh, because in some places they do recovered and...
Right. They'll show the latest football score, for lack of a better term, of how many cases, right?
How many active cases and how many recovered cases.
Maybe recovered
and active cases. I guess that's just how the state health department does it. They tell you how many are active and not, and maybe in this case they don't.
Carmen wants to know, can anyone get an antibody test in Omaha if they want one currently?
I do not know the answer to that, Carmen. I do know that, as I said, the university is going to start antibody testing, but I do not know if that's available currently for anybody. We can follow up.
Tracy writes, has anyone checked the organs of those who have died? Do they test positive? And do you know of anyone who's been on then gotten organ on a transplant list.
So, yes, there have been autopsies on people who have died of this disease. Organs are positive. Nobody has been reported to have gotten a transplanted organ from somebody who has been infected and then that individual becoming infectious.
Michaela writes, what are your thoughts on schools in Nebraska starting this fall?
So, now that's a really good question because I'm a dean of a college of public health, and I'm quite excited that we may start school in the fall here. But Michaela, I'm going to go back to my earlier statement that, we are going to put in all sorts of protections to protect our students and protect our faculty and staff. But that occurs in an environment where I want to have as little community transmission as possible. Right? That's the environment I want to start in. And that means that we need to make sure that the local public health department and the state public health department are doing their job and have the resources available to them to make sure that there's very few cases in Omaha where my students are, or in many of the places where our students are learning by distance learning and e-learning, that they're safe. And I think, if you have kids going to school from K to 12, you're going to feel the same way. You're going to send the kids to primary school, high school. And yes, you want your kids to be safe. You want their teachers to be safe, but you got to make sure the community that they're in is safe. So that part, let's not forget that part, less transmission within the community.
Otherwise, I would think it would be hard for even the kids to learn if they're thinking about everything else.
If they're worried about getting sick, it's hard to learn, absolutely.
Daniel writes, how long should you wear a cloth mask before switching and washing? How long is a use, a work shift between breaks? I think a lot of people are struggling with that. They probably wash it when they get home, but should they be doing it more?
So Daniel, I wash mine at the end of every day. So I'm very careful during the course of the day. And then at the end of the day, I throw mine in the washing machine and I pop out a new one. I guess if you wanted to be extra careful and you carry an extra one or two around with you during the day, pop them in a plastic bag during the day and then throw all three in the washing machine at the end of the day. I guess it depends on how many you have available to you, or if you're one of the fortunate ones who have many disposable ones available to you, you can throw them out during the course of the day. I don't think there's a metric to those because they're sort of a personal use item.
Mm-hmm. Well, so many people have the cloth ones because they wanted to save all the personal protective equipment for those on the front lines. Emma writes, how do we know it's safe to go out and ease back into going places, especially for someone who's pregnant and has a husband with a spinal cord injury at the C5 level?
Okay. So, Emma, that's a really good question. So there's two pieces to your question. So, number one, congratulations on your pregnancy. Emma, congratulations.
Yeah.
The good news, Emma, is most of the data suggests that unlike flu, you're not at higher risk from this disease, so that's good news. Not that you shouldn't protect yourself anyway, but you're spot on that your husband may potentially be at higher risk depending on his age and his other chronic conditions. So you still need to be cautious, like pretty much anybody as you go out. Please remember the mask, the hand washing, and the social distancing as you go out and about your work day. And again, for most people, as they go out and about, it's important to monitor what's going on in your community. And you should feel more comfortable going out every day as you see disease in your community going down every day. A good example, for example, is for those of you who are listening to me today in Lincoln, if you go to Lincoln, they have this nice little dial on the website, and their health director, Pat Lopez, hello Pat, she rotates this dial every day based on what disease looks like in their community. And as long as the dial's going down, 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 you're like, I'm feeling better about going out, out, out.
Hey, sometimes it's the little things.
It's the little things, right.
Dawn wants to know, could you touch on the pediatric inflammatory disease that we're seeing? Is it a form of COVID-19?
So, Dawn, I have to be very honest with you. There's very little known about this disease. It was first described, as I said, on August 27th, I believe, out of the UK, and a handful of cases out of Spain and Italy. Not surprising, that's where that was described, because it's a rare complication, and those are countries that had lots of cases, like tens of thousands, hundreds of thousands of cases. So that's where you're going to see that. And so not surprising, where we've seen cases, I believe the first 100-odd cases have been reported from the New York, New Jersey area. And so the disease, about 60% of kids have been between 5 and 14 years of age, and they have fever, they have signs of inflammation. So if you look in their blood, they have these markers that suggest inflammation, and they have something either going on with their heart, their liver, or heart, liver, kidney, I believe, or lung potentially going on. And it's a mix of a couple of different things we see in kids. Kawasaki is one of the diseases, toxic shock syndrome. It's currently all being figured out. It looks like it is associated with this coronavirus disease, because at least half of these kids have antibodies suggesting they were infected 2 to 4 weeks ago. So it looks like it's like a response to a prior infection that's causing this sort of inflammation to that prior infection. Like the immune system's working differently, correct.
Now, is that similar to those that the kids that you've heard about maybe weren't sick at all and then had like a inflammation in their toes or their fingers? Have you heard that? Where some kid are those two similar, or is this maybe another spoke to coronavirus?
This may be another spoke, because yet there's another spoke of this sort of cytokine release syndrome of people who think they're getting better, and then all of a sudden they're like really worse, and it's because their immune system sort of kicks in the wrong way, and it gets and their inflammatory system goes wild, and that's what really gets them in trouble. Okay. So yeah, there's a lot to learn with this disease.
And that's fairly rare, though, right? The impact on children.
Right. It's a rare. This new syndrome seems like a very rare complication.
Donnie writes, some experts say staying home and wearing your mask brings your immune system down, suggesting herd immunity is the answer. What are your thoughts on that?
So herd immunity is an attractive option. It's just a very dangerous option. So
that's where everybody just does their thing and everybody gets sick.
Everybody gets sick, right? So unfortunately, what happens when everybody gets sick is New York City and Italy, which is hospitals get flooded, healthcare workers get sick and die, and too many people get sick. Too many people get sick and die because they can't go to the hospital. So that's what herd immunity would do to you. So we'd have this amazing spike in deaths across America. So the whole reason about flattening the curve was about preventing herd immunity and preventing all these deaths. So yeah, no, herd immunity is attractive except for the death part.
Right. Chris writes, since the governor has talked about your metrics in terms of projections, is your published work something you can discuss here?
Sure, in terms of?
The metrics as opposed to the IHME model?
So there are numerous models available to look at how many deaths may happen in Nebraska. And if you go on the CDC website, they're tracking, I think, 16 different models right now. And if they're on the CDC website, you can look at the U.S. as a whole, and there's a button that you can press that lets you look at Nebraska, and you can see all the models for Nebraska, and you can see all the projections for the potential number of deaths in Nebraska. And so that's one way.
Is your model on that?
No, our model looks at something different. So that looks at the number of deaths in Nebraska. Our model, there's a link to our model off of our website, and our model looks at it a different way, which is based on when we think when the outbreak is going to peak, how many deaths are going to occur in Nebraska. And so you can look at that, and that shifts these are dynamic models, so they shift every day based on how many cases and how many deaths there are. And there's no doubt that from the original projections 4 weeks ago, now we're projecting more deaths than we did 4 weeks ago. But 4 weeks ago, it looked like we were having a small epidemic that was coming down, and then all of a sudden we had this huge wave of cases that were mainly around meatpacking facilities that increased deaths. Now, if there's a silver lining in this, and I always like to put things in perspective for people, which is that we are 2 million people. We've had 8,700 cases. So let's try to keep all of this in perspective, right? So overall, this disease has had a mild impact in Nebraska. 103 deaths. Each and every death is tragic, right? But it's 103 deaths out of 2 million people. So 103 too many, but fortunately not to the scale that we've seen in many other states and countries in America. And we want to try to keep that down. And of those 103, the majority have occurred in long-term care facilities. Most of the large cases we've seen recently have been in meatpacking facilities, and a lot of those people are younger and healthier. And so I think that's why we've not seen the accompanying deaths that you would have seen. So we've been fortunate. So in many ways, Nebraska, despite the cases and the deaths, we've been fortunate, comparatively speaking, have been fortunate. So I'd like to give people the good news with the bad news.
Is part of that based on our geography? We've got like a couple of 3 big cities and then very rural.
They're rural. We don't have the density, and so we've been fortunate in that way, I believe. But the geography comes back in the other direction too, right? It's because of the meatpacking plants that we have the cases right now.
Right. What can be done to limit the cases at the meatpacking plants?
And there's a lot being done. So kudos again back to the governor, ag, public health. They've been all working out there. The university has been working out there. The meatpacking facilities, the communities, local health departments, to work together to think about what do they do to decrease transmission within the facilities. Giving people time off, sick leave. If you're elderly or have high risk conditions, please don't come to work. We'll still pay you. Splash guards, all sorts of things that they've been doing. But you just need to put in more work within the community to decrease transmission within the community also.
That once you find that case, try to stop it from
cutting chains of transmission.
Right.
There you go. You'll be an epidemiologist by the end of this hour.
Sounds like a new band, doesn't it?
Chains of transmission.